Welcome. This is Yvette Gaughan. I am a registered dietitian with the Medical Affairs Department with Nestle Healthcare Nutrition, and I am delighted to introduce today's speaker and assist with today's webinar, which is entitled Nutrition-Focused Physical Assessment, Part 3, Micronutrient Deficiencies. This is actually the third webinar of our third-part series. Financial support for this presentation was provided by Nestle Healthcare Nutrition. The views expressed are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented and is for educational purposes only. It is not intended as a substitute for medical advice. So with that, I'd like to introduce Dr. Frank. She is a registered dietitian and holds a Bachelor's of Science in Nutritional Science, a Master's in Nutrition and Dietetics, and a doctorate in exercise physiology. While working as a postdoctorate fellow for the University of Washington, she also received a master's in public health in epidemiology. Dr. Frank has published several peer-reviewed articles and book chapters. And currently, Dr. Frank is clinical assistant professor and director preceptor of clinical sites for the coordinated program in dietetics in the Nutrition and Exercise Physiology program at Washington State University in Spokane. She is also the owner of Frank Nutrition and Exercise Consulting, and she works closely with malnourished patients providing nutrition intervention to maintain and promote lean body mass and replete nutritional status and improve health outcomes. Dr. Frank is active in several nutrition organizations and has spoken at the local, state, and national level regarding changes in the healthcare landscape and elevating the role of the dietitian in nutrition assessment, physical assessment, and evidence-based nutrition intervention to treat the malnourished, hospitalized, and or those that are community dwelling. And so with that, I am honored to turn this presentation over to Dr. Frank.
Well, thank you, everybody. And again, I'd like to welcome all of you to our third series on micronutrient deficiencies encompassing nutrition-focused physical assessment. Now, I'd like to go over some call to actions from webinar part 1. And the dietitian is the appropriate expert to identify and treat patients for malnutrition. And you're going to see a common theme throughout my webinars where I really would like us to underscore these characteristics to engage and explore and elevate. And our main goal would be to improve patient outcomes. And we need to do that by engaging in physical assessment as part of the nutrition care process. Before you engage in physical assessment as part of the NCP, I encourage you to set the stage for success through institutional and collaborative support. And we discussed ways to do that in webinar part 1. Also, your role would be to explore the severity of malnutrition and document with appropriate language to help drive coding and reimbursement. And finally, to elevate the role of nutrition in healthcare to meet the PPACA, which is the Patient Protection Affordable Care Act mandates, such as decreased length of stay, reduction in hospital costs, and help prevent hospital readmissions. Let's talk about some call to actions from webinar part 2. This is where we would use nutrition-focused physical assessment to identify the severity of malnutrition. We can assess changes in body composition, such as a degree of loss of lean body mass, loss of subcutaneous fat mass, and fluid accumulation. We can also use physical assessment to look at changes in functional status, for example, using the hand grip dynamometer. I encouraged you to initiate a plan of action at your facility to incorporate physical assessment effectively and to collaborate with team leaders such as clinical nutrition managers and other nutrition ambassadors who advocate for the RD to be the expert in malnutrition identification, treatment, and prevention to improve patient outcomes. We have lots of objectives today. First, I'd like to discuss how the 6 characteristics to identify malnutrition may lead to clinical pitfalls in the recognition of micronutrient deficiencies, and to describe the role of nutrition-focused physical assessment in identifying signs and symptoms of micronutrient deficiencies. I don't have a lot of time to discuss laboratory measures, but I will briefly describe laboratory measures that can be ordered to assess specific micronutrient deficiencies. And then I will also briefly discuss some confounders and clinical correlations regarding laboratory assessment. So let's have a comprehensive look at malnutrition. And you've seen this slide consistently throughout my webinars. These characteristics were identified by the Academy Malnutrition Workgroup, Aspen Malnutrition Task Force, and the Aspen Board of Directors, and were published by White et al. In 2012 in the Journal of the Academy of Nutrition and Dietetics, as well as the Journal of Parenteral and Enteral Nutrition. Your adult patient can be identified as having malnutrition if they present with 2 or more of the following characteristics, including insufficient energy intake, unintentional weight loss, loss of muscle mass, loss of subcutaneous fat, fluid accumulation, and diminished function. Note that we have spent the last 2 webinars discussing these characteristics, including the degree of impact over a time frame, which would identify your patient as having non-severe compared to severe malnutrition. We also discussed the role of the dietitian in the identification of non-severe versus severe malnutrition through engaging in NFPA for changes in body composition and functional status. It was also emphasized that the RD needs to understand the different biologic drivers behind the scene when considering etiology-based malnutrition, including starvation-related, chronic disease-related, and/or acute illness or injury-related malnutrition. Furthermore, the importance of documenting the severity of malnutrition to assist in proper coding and reimbursement was discussed. Now I'm going to play devil's advocate and ask, are these characteristics comprehensive enough? The primary focus of these characteristics are to aim at diagnosing or giving an assessment of a loss of muscle and fat mass, and also to judge the degree of diminished function. Patients who do not fit these 6 characteristics but present with micronutrient deficiencies may fall through the cracks. Now, I'm going to give you an example of a type of patient who may fall through the cracks. And since I am a bariatric dietitian, I'm going to be talking a lot today about personal experience in micronutrient deficiencies. And with post-bariatric patients, they often fall through the cracks when we rely on the 6 characteristics of malnutrition because they are aiming for intentional weight loss versus unintentional weight loss. Or they have large BMIs, BMIs over 30, and therefore they're thought to be very healthy and not at risk for malnutrition. Furthermore, they're difficult to assess changes in body composition due to sarcopenic obesity. So I want you to keep this type of patient in mind and make sure that we're not desensitized when we get auto-generated protocols to assess our patients and to conduct a full nutrition assessment. It is important that the RD engage in critical thinking and utilize skills from physical assessment, including visual inspection of shape, color, symmetry, and movement to detect any suspected micronutrient deficiencies. I have been an expert consultant on several cases where the dietitian had missed the fact that micronutrient deficiencies were present. These patients also fell through the cracks and were assumed healthy due to, say, a normal or high BMI, while others were only diagnosed with protein energy malnutrition without regards to micronutrient status. As nutrition experts, we cannot allow our patients to be either misdiagnosed or underdiagnosed with regards to micronutrient deficiencies. Some micronutrient deficiencies have an irreversible sequelae with deleterious outcomes. It is time to become the dietitian detective to identify all types of malnutrition and treat accordingly. Let's explore the tools in the toolbox to identify micronutrient deficiencies, as well as the head-to-toe signs and symptoms associated with several micronutrient deficiencies. This slide was shown to you in Webinar 2 when discussing the tools in the toolbox. Note that the ones with the asterisks denote tools that can help you identify signs and symptoms of some micronutrient deficiencies. They include the sterile tongue depressor, magnifying glass with light, a small flashlight or pen light, and a neurological reflex hammer. Now, slides 12 through 18 are overview slides which discuss the head-to-toe signs and symptoms of several micronutrient deficiencies. I will be using many terms that you have probably heard before, but you may not remember their definition. So I have included a brief glossary to help you if you need to be reminded. You can view this glossary on your own when you review this presentation. I will be briefly going over these slides and then spending time highlighting signs and symptoms of several nutrient deficiencies. As you can see, these tables emphasize the point that nutrition does not occur in a vacuum, and that most clinical manifestations associated with micronutrient deficiencies are polynutritional, meaning that more than one micronutrient deficiency is often present. It's your job to become the expert in the identification of these deficiencies and to use evidence-based practice strategies for proper repletion. Now, let's pretend that you have introduced yourself to your patient and have explained to them that you are there to perform a physical assessment exam. You have told them your goals, and you are going to be explaining to them that you're going to assess for changes in body composition, as well as any signs and symptoms of micronutrient deficiencies. You've put on your sterile gloves and have gotten out your tools in the toolbox, such as a pen light or magnifying light, and you begin a head-to-toe physical assessment. As you can see by this slide, we're going to start with the eyes. Clinical manifestations of vitamin A and/or zinc deficiency may include vision impairment, such as night blindness or blindness. Now, the metabolisms of vitamin A and zinc are closely related. Thus, the dietitian must be aware of these interrelationships. I will be briefly explaining some interrelationships in metabolism of several nutrients throughout my talk today. Other visual impairments, such as photophobia, may be associated with riboflavin or vitamin B2 deficiency. Deficiencies in several nutrients may affect the color, shape, and moisture of the eye. Furthermore, deficiencies in thiamine and/or vitamin E may impact the movement of the eye and result in paralysis or rapid eye movement known as nystagmus. Next, we will examine the inside and the outside of the mouth, including the lips, gums, and tongue. Several nutrient deficiencies may manifest by impacting the color, texture, shape, and moisture of the lips, mouth, and tongue. Most often, B vitamin deficiencies are responsible for mouth or lip lesions, including chelosis or angular stomatitis. I have pictures of this a little bit later on in my presentation. Bleeding gums, however, are often due to vitamin C deficiency and possibly vitamin K. Vitamin B deficiencies often impact the color, shape, and texture of the tongue from the base to the apex, affecting what are called the filiform and fungiform papillae. You can use your magnifying tool with light to examine the mucosa of the mouth as well as the entire area of the tongue. Note that oftentimes visual inspection without a tool is sufficient to detect clinical manifestations. Patients who complain of loss of taste or impaired taste may be at risk for zinc deficiency. Furthermore, the constellation of B vitamin and zinc deficiencies may manifest as burning mouth syndrome. I have provided for you a illustration of the tongue to explain where the base, body, and apex are located, and to denote that the papillae are distributed throughout the tongue. And it is important that you look at the entire mouth area. Now let's look at the hair. Several micronutrient deficiencies will impact the color, shape, texture, and moisture, and distribution of hair. Note that protein deficiency will impact the quality and quantity of hair. And furthermore, several micronutrient deficiencies, including but not limited to zinc, vitamin C, and vitamin A, will result in changes in hair quality and/or quantity. Micronutrient deficiencies can also impact the color, texture, and shape of the skin. For example, pale skin may be due to deficiencies in iron, folate, or vitamin B12, and liver spots may be associated with vitamin E deficiency. Patients presenting with dermatitis may be showing signs of several nutrient deficiencies, including several B vitamins, as well as vitamin E and/or zinc. Furthermore, deficiencies in vitamin C or K may manifest as petechiae, purpura, or ecchymosis. And again, if you need help with these definitions, please refer to the glossary at a different time. Finally, you will examine your patient's nails. Micronutrient deficiencies can also impact the color, texture, and shape of the nails. A classic example here are spoon-shaped nails, or cholinikia, caused by iron deficiency. Furthermore, signs of protein energy malnutrition can result in horizontal ridges of the nails known as Bowes line, or horizontal hypopigmentation known as Murex lines. I have these illustrations to show you. You can see that on the illustration under Murex lines, this individual is showing hypopigmentation. This can be due to protein deficiency and/or copper deficiency. Bowes lines are horizontal ridges on the nails, and these would indicate times of severe malnutrition, especially protein energy malnutrition. Now, as discussed in webinar 2, your role in physical assessment is to assess the degree of and the location of fluid accumulation. As discussed in webinar 2, fluid accumulation is related to low albumin, often driven by the inflammatory process. However, peripheral neuropathy, and in particular lower extremity edema, may be a sign and symptom of wet beriberi caused by thiamine deficiency. So we can see that thiamine can impact the degree of edema and peripheral neuropathy found in an individual. I also want to note that polynutritional deficiencies may cause peripheral neuropathy in your patient. You can see here by this slide that we have several nutrients that may manifest as peripheral neuropathy, including thiamine, niacin, pyridoxine, pantothenic acid, cyanocobalamin, biotin, vitamin E, and copper. Therefore, you play an integral role in identifying these micronutrient deficiencies. I encourage you to look at them as polynutritional and as individual. And it's very difficult to suss them out. So sometimes what we do is we have to treat them as a group. For example, with a B complex, if you will, or a banana bag, which is going to be a combination of several nutrients like thiamine, folate, vitamin B12, and other micronutrients. So what would I like to do now is I'd like to encourage you to visualize yourself doing a physical assessment in the room like you just did, and what you just did was a head-to-toe nutrition-focused physical assessment. And now what I'm going to do is I'm going to emphasize individual nutrients to spell out some key signs and symptoms of individual micronutrient deficiencies. It is very rare to find somebody with just one micronutrient deficiency, however, but I felt like this is the easiest way for me to emphasize the signs and symptoms of key nutrient players. Thiamin is vitamin B1, as you know, and thiamin deficiency is something that I come across very often. I've been involved as a witness a wrongful death case. I've been a consultant on many cases here at the hospital. Unfortunately, most of these patients are post-bariatric patients that I've dealt with. However, patients who are alcoholics are also at risk for thiamin deficiency. I'm so passionate about this topic, in fact, that I wrote a review paper. It's a tutorial called Thiamin in Clinical Practice, and it was EPUB ahead of print, so it was published in January in JPEN, and I have that full reference for you in the back. All of my references are listed for you at the end of this presentation. And this is a very comprehensive article. I encourage all of you to read it, and in fact in the July issue of JPEN it will be offered as a continuing education paper, and so you can even get some CE credits by reading it and answering some simple questions. Now, with minor vitamin B1 signs and symptoms, I want to underscore that we know this as beriberi, and there's dry beriberi and wet beriberi. Dry beriberi means that there's no edema. Typically, these patients will present with ataxia, which is an unsteady gait. They'll have peripheral neuropathy, and they'll also have symmetrical foot or wrist drop. Wet beriberi will have that edema, and typically speaking, it's peripheral edema, and especially in the lower extremities. They'll also present with tachycardia. I've had several patients with Wernicke encephalopathy, which is a more advanced symptom of thiamin deficiency, and this would include the classic signs of ataxia, the ophthalmoplegia or the paralysis of the eyes, also the nystagmus. Now my cartoon here is showing you that the eyes will have a quick jerk to the right and a slow drift back to the left. Also my other cartoon is a person who is having an unsteady gait. You can also test for proprioception by having them do the Romberg sign, and individuals will often present with altered mental status. This is also known as confabulation. They will have short-term memory loss often, and I asterisked the last one, psychosis, because if they do show signs of psychosis, then they do have a condition called Wernicke-Korsakoff syndrome. And I've had several patients with psychotic episodes. So oftentimes you're collaborating with psychiatrists and other medical professionals with this individual, but please note that, again, the medical diagnosis may indeed have a nutrition etiology. So I please encourage you to be the dietitian detective on the scene for that. Risk factors of thiamin deficiency include prolonged intractable vomiting, refeeding syndrome, non-adherence with vitamin and minerals after GI bypass, severe excessive weight loss, and believe it or not, small bacterial overgrowth will also plummet thiamin stores. Now patients, as I said before, people with alcoholism are at risk for several of these micronutrient deficiencies. Post-bariatric patients, also people who are critically ill and are on nutrition supports, renal failure patients, cardiac failure patients, people with neurodegenerative diseases, as well as individuals with diabetes. So I'm going to leave thiamin now, but I do encourage you to look up that paper and read more about the comprehensive nature of thiamin in clinical practice. Next, I'd like to talk about riboflavin deficiency, and I have a few pictures here to show you. A magenta tongue or a red tongue is generally indicated of riboflavin deficiency, as well as glossitis or smooth tongue. Chelosis or angular stomatitis is shown in the lower illustration, where you have lesions on the sides of the lips. Also, hyperemia and edema of the pharyngeal and oral mucosa. Blepharitis, which is inflammation of the eyelid, may be present, corneal vascularization, photophobia, and several forms of dermatitis. Now, typically speaking, dermatitis is found around the face, the nasolabial area, also in the scrotal area or the labial area for women. So it is up to you how in depth you want to do your physical assessment on your individuals. Again, risk factors would be alcoholism, thyroid disease because it alters the metabolism of this nutrient, as well as diabetes because it increases the excretion. I have a brief slide on seborrheic dermatitis. There's an article that was written by Robert Schwartz in 2006. These are slides from his paper, and the individual on the left is showing you seborrheic dermatitis around the nasolabial area, and you can see the marked erythema there, and also you can see dermatitis on the back of the individual on the right. Now, niacin deficiency has some classic signs. We all learned it as pellagra, and the 4 Ds associated with pellagra are diarrhea, dermatitis, and the dermatitis also is known as Castle's necklace, and you can see the images there. These are typically changes of the skin. It resembles a sunburn at first and then darkens. Also included is the desquamation of sun-exposed areas. Also, dementia and neurological manifestations would be present, like headaches. You might have loss of memory, confusion, disorientation, and even paralysis of the extremities. And unfortunately, if this is not treated, then your individuals will die. Other nonspecific signs and symptoms would be poor appetite, abdominal pain, nausea, vomiting. Many of those mouth changes we discussed for B vitamins, such as glossitis, angular stomatitis, and chelosis. Again, alcoholism is a great risk for vitamin B3 deficiency, also protein calorie malnutrition, or people who have Hartnupp's disease, other people with gastrointestinal disorders, and those with liver disease and or cirrhosis. Vitamin B6 or pyridoxine deficiency can also be present in your patients. Again, the constellation of those mouth changes, glossitis, chelosis, angular stomatitis again, blepharitis, and seborrheic dermatitis can be present. Now, B6 deficiency can also manifest as neurological signs and symptoms, the ataxia, peripheral neuropathy. In fact, people can have abnormal EEGs, and convulsions can be present. And I also want to encourage you to explore the possibility of B6 deficiency if you have refractory microcytic hypochromic anemia. Now, these microcytic hypochromic anemia can also be associated with iron deficiency and or copper, but again, if it's refractory to treatment, you might want to consider the deficiency of pyridoxine. Furthermore, several metabolism effects can show an indication of pyridoxine deficiency. For example, if your patients have impaired niacin synthesis from tryptophan, they may be at risk for this nutrient deficiency. And this nutrient deficiency may manifest as hyperhomocystinemia due to the role of B6 in this metabolism. Furthermore, there may be a decreased activity of several transaminases like your liver function enzymes, for example, because vitamin B6 is needed for the active form of pyridoxal phosphate, which is the coenzyme form of pyridoxine. Several risk factors, again, would be alcoholism and several medications. So I encourage you to go back and just digest this information on your own due to the fact that I can't read every bullet to you today. Now let's skip to biotin deficiency. Biotin deficiency, I think the most common sign and symptom of biotin deficiency would be alopecia or hair loss, but other deficiency signs could include muscle pain and dermatitis and several neurological symptoms. Now, risk factors include genetic mutations and ingestion of raw egg whites, gastrointestinal disorders, alcoholism again, and several medications, including those that are anticonvulsants. Now, I have several pictures identifying vitamin C deficiency. We have 4 classic H's, which would denote vitamin C deficiency. These include hemorrhagic signs, and those would be your petechiae, your purpura, ecchymosis, and also hyperkeratosis of the hair follicles. Hypochondria and hematologic abnormalities may be present with vitamin C deficiency. These show the hyperkeratosis of the hair follicles. Also, I don't have a slide showing this, but you might have corkscrew hairs coming out of those hyperkeratosis. And you can also see slides that are showing you what are purpura and petechiae. Those are just degrees of the hemorrhages that are happening below the skin. And we have several risk factors, include those who smoke, again, those who are alcoholic, malabsorptive syndromes, diabetes, and patients with cancer. Now, vitamin B12 and folate are married in metabolism. Both of those in deficiency states manifest as megaloblastic macrocytic anemia. I do need you to understand that if it's called pernicious anemia, then it's because it has to do with the intrinsic factor, either the binding or is impaired or the absorption of the intrinsic factor, and vitamin B12 would be impaired. And this would be an example if you had someone who has Crohn's disease, for example, because vitamin B12 is absorbed in the ileum, and that's typically the area where Crohn's patients are affected. Now, B12 deficiency can also manifest as low white blood cell count, so leukopenia, and low platelet count, thrombocytopenia. Now, my picture here is showing you the magenta tongue again, where you're having a big red beefy tongue with glossitis. You can see that smoothing of the tongue due to the loss of the fungiform and filiform papillae. Neurologic deficits are also present with vitamin B12 deficiency, including, again, the ataxia, loss of proprioception. It's key that you have a loss of vibration sense. This is where you could use your reflex hammer to do some physical assessment. Also, mood changes or depression can be a common manifestation, as well as memory loss and dementia and psychosis. Folate deficiency normally does not present as neurological deficits, but again, classic sign would be the megaloblastic macrocytic anemia, as well as fatigue and weakness. And you can also measure for homocysteine, because folate deficiency will increase the risk of hyperhomocystinemia. It will also manifest as low platelets and or low white blood cells. You will have those mouth changes, and diarrhea can be present, as well as some depression and confusion. We have several risk factors for both B12 and folate deficiencies. Mainly alcoholics are at risk for this. Anybody who's at risk for achlorhydria, for patients who are on H2 blockers, PPIs, people who have had gastrectomies or gastric bypass, malabsorptive disorders. Several medications can cause these nutrient deficiencies. And one note I will make from small bacterial overgrowth, you will find a decrease in B12 with a concomitantly high folate value. So that is something you should understand if you do have patients with small bowel bacterial overgrowth. Now I'm going to jump to the fat-soluble vitamins, and typical symptoms here for vitamin A deficiency would be poor wound healing. Also, the follicular hyperkeratosis can be present. We did talk about the fact that vitamin A can develop into night blindness or nyctalopia. And I have a slide here showing you what a Bitot spot is. I've also heard it called a Beto spot. And this would be a little white spot on the sclera. Also, people would be at risk for xerophthalmia or keratomalacia. depending on the severity of the dryness of the eye. Patients may also present with nasolabial seborrhea. And it is key that you note that iron deficiency anemia may be present among people who have iron deficiency anemia, people who have deficiencies in vitamin A, because vitamin A is needed for iron incorporation in red blood cells and mobilization from the stores. Now, I did not have a slide for vitamin D, but as you know, metabolic bone disease would be present in individuals with vitamin D deficiency, but I didn't include it because that's not really typical that we look at for physical assessment. But we do use physical assessment to judge for vitamin E and or K deficiencies. Vitamin E deficiency can manifest as hemolytic anemia. Also, the peripheral neuropathy and nystagmus could be present, and also loss of coordination of the limbs. Petechiae might be present, and the ceroid pigment or liver spots can also be due to vitamin E deficiency. And vitamin K deficiencies are usually from defective blood clotting or hemorrhages. So again, you would look for the petechiae, purpura, and ecchymosis. Dark circles under the eyes are sometimes blamed for vitamin K deficiency. Also, bone changes like osteopenia and osteomalacia can be due to vitamin K deficiency. We're going to jump to some mineral deficiencies. So, iron deficiency, we have a picture here of the spooning of the nails, or conychia, and I have actually seen this in my patients. You can also have vertical ridges on the nails, and those are a little bit more nonspecific. But your patients would typically present with microcytic anemia, and they would have pale skin, fatigue, shortness of breath, and also they might have what are called anemia eyes or pale conjunctiva of the eyes. Secondary diagnosis for spoon-shaped nails include hemochromatosis, Raynaud's disease, and lupus. Several risk factors for iron deficiency would be heavy bleeding and also achlorhydria. Now I'd like to discuss copper deficiency. I've had several post-bariatric patients with copper deficiency, and copper deficiency manifests very similarly as vitamin B12 and folate deficiency. So I will warn you that it is difficult to put your detective hat on and be able to determine, is it copper, is it B12, is it thiamine? And that's why I'm encouraging you to look at it in a polynutritional nature, but always also know your facts when it comes to the signs and symptoms of individual micronutrient deficiencies. So copper deficiency has the ataxia, the bilateral paresthesias, neutropenia, leukopenia, thrombocytopenia, and pancocytopenia. Also, as we discussed, hypopigmentation or depigmentation of the skin and hair, and other abnormalities. I also want to spend a second talking about the fact that copper deficiency will be hypochromic, microcytic, but it also can be macrocytic. So it's very difficult to understand the anemia that is associated with copper. The references that I have provided for you are interesting because some patients did present with microcytic anemia, some patients presented with normocytic anemia, some patients presented with macrocytic anemia. Now, I venture to guess that they had other nutrient deficiencies going on to drive the morphology of that red blood cell. Now, high oral doses of zinc will affect copper, and so we do need to be mindful when we replete individuals with zinc. Zinc and copper compete for metallothionein and uptake in the GI tract, and so what we need to be mindful about is we don't want to over-supplement with zinc over a very long time, because unfortunately we could make our patients copper deficient by doing so. Also, several PPIs will diminish copper absorption, And we also need to note that in nephrosis and hemodialysis, patients would have an increase in copper losses. Malabsorptive disorders such as celiac disease, Crohn's disease, and ulcerative colitis will also affect copper status. And I also want for you to understand that people with liver disease and impaired bile excretion may actually have copper toxicity and not deficiency. Now, I really find zinc deficiency very, very interesting. Now, with moderate signs and symptoms of zinc deficiency, you will have the typical changes in taste, right? So your patients would present with hypogeusia, decreased taste sensation, and also alterations in the senses, smell, or taste, which is known as dysgeusia. They also might have poor appetite, poor wound healing, impaired immune function, and impaired night vision due to the marriage of zinc and vitamin A in metabolism. Now, with more severe signs of zinc deficiency, you will have patients with alopecia, bullous pustular dermatitis, where I have a slide for you here showing these fluid-filled lesions. And I actually have a patient who presented that way, again, a post-bariatric patient. It is interesting when you have a patient with such a rare sign and symptom of zinc deficiency. Also, acrodermatitis enteropathica. This is very similar to the seborrheic dermatitis, and it typically presents around the nasolabial area. Now, patients at risk for zinc deficiency include those with protein deficiency due to their interrelationship. Medications such as PPIs and H2 blockers, again, malabsorptive disorders, intestinal bypass, and especially if you have a patient with long-term steatorrhea and diarrhea, please assess for deficiency in zinc. So now I'm going to switch gears and talk a little bit about labs, and I would love to spend more time on this. I am a lab girl. But we need to understand the impact of inflammation on biomarkers and also to understand limitations of laboratory assessment. They're either too expensive, they have a long lag time. Sometimes you don't get the labs back until up to 2 weeks and your patient's already gone by then. Maybe they're not available and they have limitations with sensitivity and specificity. Now, I developed these tables for you to summarize the deficiency signs and symptoms. And I've also listed some pertinent other information to give you more clues. So what I encourage you to do is to do your physical assessment at the bedside. Write down what nutrient you think is deficient. Look at other signs and symptoms based on information from the electronic medical record and from patient report, and then look at labs that can help you. Now, for those of you who printed off the handouts prior to today, I would like you to add whole blood thiamine to that thiamine. I thought that was funny that I forgot that, because whole blood thiamine is actually the best way to measure thiamine. But I do want you to understand that there's so much to discuss with labs, and unfortunately, I won't be able to get to the heart of this. But the primary confounder of laboratory assessment is really inflammation, and this concept was discussed in webinar 2. Remember that during the acute phase response, the positive acute phase proteins will be elevated, and there will be an inverse relationship with negative acute phase proteins, namely biomarkers used often to assess nutritional status such as albumin, prealbumin, retinol binding protein, and transferrin. You should also understand that several nutrients such as thiamine are carried by albumin, and thus low albumin status would most likely impact the assessment of thiamine by serum or plasma methods. The best way to measure thiamine, as I said, is by whole blood. However, this assay is difficult to find and is more expensive, and it has a long lag time. However, if you suspect a patient has thiamine deficiency, I urge you to empirically treat, because thiamine deficiency can have an irreversible sequelae and result in neuronal cell death. My paper spells this out very clearly, so I do encourage you to look that paper up. Other key clinical correlations that I will point out are with B12 and folate deficiencies. These nutrients are interrelated in metabolism and are involved in the maturation of red blood cells. Elevated mean corpuscular volume, or MCV values, can suggest deficiencies in B12, folate, or both. A concomitant elevation of methylmalonic acid will allow you to rule out folate deficiency and know that MCV is elevated due to vitamin B12 deficiency or other reasons. I have mentioned several interrelationships of nutrients throughout my talk today and hope that you can appreciate the complexity of metabolism. The dietitian is a key player in the detection of deficiencies, and we are the few discipline who understands metabolism and the signs and symptoms of deficiencies. Vitamin A, zinc, and protein metabolisms are closely linked. So we do need to keep that in mind when we're assessing for vitamin A. For example, protein deficiency can result in low prealbumin and impaired production of retinol binding protein. And vitamin A depends upon prealbumin for mobilization from the liver, and retinol binding protein is used as a measure for vitamin A status. Therefore, in patients with protein deficiency, vitamin A status, if measured by retinol binding protein, will be low and may not be a true reflection of vitamin A stores. Furthermore, zinc deficiency results in decreased synthesis of several of our transport proteins, albumin, prealbumin, transferrin, and retinol binding protein. And zinc is required for alcohol dehydrogenase activity, which converts retinol to retinal. Finally, zinc deficiency is associated with a decreased mobilization of retinol from the liver, even despite adequate vitamin A stores. Finally, I have listed some key minerals where physical assessment can help provide clues for suspected deficiency. Again, note that zinc status can be influenced by the acute phase response, and the best laboratory assessment will be either red blood cell or white blood cell zinc and urinary zinc. You can also assess zinc status from the hair, but be aware of topical products that may confound these results. Now quickly, I would like to discuss the fact that copper status can be tricky to assess because the carrier protein ceruloplasmin is a positive acute phase protein and thus is elevated by the inflammatory state. Therefore, if your patient presents with low ceruloplasmin despite an elevated CRP, you can probably be sure that your patient is copper deficient. I also want to briefly mention iron status as well. Iron deficiency will result in low red blood cell, hemoglobin, and hematocrit. I have a typo on my original slide where I denoted the TIBC being low. This is true if your patient has anemia of chronic disease. But if your patient has iron deficiency anemia, then the TIBC will be low. So please change that. Will be high. So please change that. Furthermore, iron deficiency anemia will most often have low ferritin values reflecting low storage of iron. However, ferritin is a positive acute phase biomarker and thus again will be influenced by inflammation. So I have quickly gone through the tip of the iceberg when it comes to clinical correlations and confounders with labs, and to give you an idea of how I would go about with my assessment to judge the degree of malnutrition driven by micronutrient deficiencies. Now we have several summary statements today, and I feel like I'm repeating myself, so I'm just going to briefly go over these. It is true that we have these 6 characteristics of malnutrition to identify the adult with several forms of malnutrition, but mainly they're looking at protein deficiency, looking at loss of muscle mass, looking at changes in fat mass and fluid accumulation, diminished function, unintentional weight loss, and insufficient energy intake. I encourage you to avoid clinical pitfalls and also look for any signs and symptoms of micronutrient deficiencies. I am encouraging you today to engage in that physical assessment at the bedside, to use labs to help you. Know your metabolism. Understand the influence of correlations and confounders, especially inflammation, and to elevate your role as an advanced dietetic professional. We have several calls to action and summaries. We know that physical assessment can be a powerful tool. And although a thorough physical assessment may take up to 20 minutes, and this includes doing the hand grip dynamometer, really it takes less than a minute to identify the severely malnourished patient. So pick your battles and do what you can do. Your call to action today is to develop policies and procedures to make physical assessment a part of the nutrition assessment model. So thank you, and again, to summarize, engage, explore, and elevate. Do you have any questions for me today?
Yes, we do, Dr. Frank. Thank you so much. You have provided us with a wealth of information, and I know to your point that it's a lot of information to try to get into all the nitty-gritty details, and I think you did an excellent job providing an overview when it comes to assessing micronutrient deficiencies. So thank you for that. What I'd like to do is put forth a couple of questions that we have received so far, and I do see that several are coming in. So what I'd like to do is start with our first question we have is addressing our role as a dietitian and working with our colleagues, more specifically physicians. As you've mentioned, lab values can be very effective in giving us that additional information to know how to provide further assessment or nutrition intervention. What have you done, or what would you recommend when it comes to working with the physicians to make sure they're on board with recommending these lab values or to do these lab tests?
What I've done in the past is I've talked to my physicians about the role of the nutrient. So I will spell out to them if I suspect that someone has a nutrient deficiency. And let me just pick on thiamine, since I've had so many patients with thiamine deficiency. For example, I had a patient where the doctor said there was no organic cause for thiamine deficiency. And yet this patient had high lactate values. However, all the worries of a cardiac failure was ruled out because they had a normal troponin, and so the doctor said that there was no organic cause for the hyperlactasemia that this patient was presenting with. And I simply said, well, I beg to differ, because thiamine is needed for, and I went into the metabolism of needing thiamine in the metabolism to push pyruvate into the Krebs cycle. And I just go through the metabolism, and then I say, I think that we should either test for thiamine, and if you don't want to do that, then let's empirically treat, because we will have deleterious outcomes if we don't. And I've had very good luck when I talk about science. So that's what I do. And then I also have to understand, are these labs that I want to measure, A, available? Are there correlations that may confound them? And does my patient need to pay for that, or does their insurance pay for that? Several times I have opted not to measure labs because I've been told that that cost is passed down to my patient. And if the patient's a Medicare patient or has financial restrictions, I don't put that burden on the patient. Otherwise, I love to play with labs, and I'm a lab girl, so I just talk to the doctor and the pharmacist and other people to figure out what can I measure and what lab in my area will assess for that nutrient.
So expanding on that, do you recommend, especially for the patients where you decide it's not necessary or the situation does not lend itself to doing a lab value and you suspect there's a deficiency, then would you recommend a multivitamin? And is that what would be your approach for your patients in general, or recommendations for those that may have a micronutrient deficiency?
Yeah, and that's a hard one because it really depends on the patient and the severity of the suspected micronutrient deficiency. So in mild deficiencies, I think that a micronutrient given by a multivitamin may be sufficient. But let me give you an example of thiamine again. If I had an individual who presented with Wernicke encephalopathy and or Wernicke-Korsakoff, I will even go up to 500 milligrams once, twice, or 3 times daily. And that is a lot of thiamine, right? But that's what the research shows. And again, I encourage people to read my paper. For instance, with bariatric surgery patients, at least 500 milligrams once a day is necessary, and the European recommendations are 200 3 times a day, and there are other evidence-based practice standards of 500 milligrams up to 3 times a day, and that research has come out of the Royal College of Physicians from the alcoholic patient. So we do need more high-quality prospective studies in America and in Europe to look at the applicability of standards for the alcoholic patient put on the bariatric patient. And I look forward to that in the future.
And so do I. I really appreciate your time, Dr. Frank. It appears that we are out of time. So I, again, want to thank you so much for a fabulous presentation. And I'd like to thank all of you participating on today's webinar. As a reminder, this webinar is the final third webinar of the third-part series. And so on behalf of the Nestle Nutrition Institute, we do hope that you found this information valuable to your practice, and we hope you enjoy the rest of your day. Thanks again.